As we are waiting for folks to come in, maybe we'll do a soft rolling start with some housekeeping and then some intros. So good afternoon, everyone. Welcome to the July edition of the Evidence-Based Services Committee, or EBS Committee Roundtable. The Roundtable has been a strong and long-going tradition hosted by the Child and Adolescent Mental Health Division here in the state of Hawaii. And today's presentation will center on Hawaii's major child-serving state agencies, collaboratively addressing the impact of COVID-19 and steps moving forward. A couple of housekeeping announcements. First, that we have the pleasure, CAMD has the pleasure of partnering with social work in a variety of ways, and specifically for this presentation. This presentation has been approved by the National Association of Social Workers Hawaii chapter for up to 1.5 social work CEUs. If you're interested in receiving social work CEUs, you must fulfill two requirements. First, you must enter your name and email address at the beginning of a forthcoming Qualtrics survey. This survey will be provided via email after the roundtable. Please be sure to enter information that matches your Zoom free registration information, such as your email address and your first and last name, as you would like to appear on your social work CEU certificate. Second, and very important, please note that this Zoom webinar automatically tracks your time in session, which can be found in our Zoom usage reports, and consistent with guidance from institutions such as the University of Hawaii at Manoa's School of Social Work. This metric of time in session will be considered in awarding CEUs, and you'll be expected to attend at least 90% of today's webinar to be considered for the awarding of CEUs. Finally, before we turn it over to our first presenter, whichever email that you used for today's roundtable, please also be on the lookout. So in addition to the social work CEUs, we will be sending a satisfaction and quality improvement survey at the end of this presentation. And regardless of whether or not you are filing for CEUs, if you could fill that out, that would be great. We're always looking to quality improve and always benefit from a variety of suggestions from participants. Moving us onward, we have the pleasure of having three major components for today's presentation, all within the state of Hawaii: the Department of Education, CWS, Child Welfare Services, and the Child and Adolescent Mental Health Division, State of Hawaii Department of Health. We will be starting off with the Department of Education, Dr. Toli Amaxopoulos, and I will do a quick introduction. Dr. Amaxopoulos, doing my best I can, Toli with that name, sorry. Grew up in upstate New York. He graduated from Nazareth College with a degree in education and moved to Hawaii to teach at Kapolei Middle School in 2006. During this period, he was reading psychology textbooks in his spare time, which prompted him to apply to graduate school. And he later went on to earn his doctoral degree in clinical psychology in 2015 and became a licensed clinical psychologist thereafter. He has worked for the Department of Health, and is currently with the Department of Education, where he conducts emotional and behavioral assessments and provides supervision to behavioral health specialists. He also works with kids and adults, helping them work through depression, anxiety, ADHD, and other problem areas. Throughout the COVID-19 pandemic, he has been providing webinars to empower parents, teachers, and caregivers to support children's mental health concerns. Dr. Toli works with various modalities, including neurofeedback, PTSD somatic treatment, and is a certified AMEN clinical brain health coach. His favorite part of his job is explaining complex concepts in applicable ways to help others learn and grow. And in his off time, Dr. Toli exercises daily, travels, creates motivation content, and loves trying out new restaurants. So without further ado, welcome Dr. Toli, and thank you again for your presentation. Turning it over to you now.
Thank you. Share my screen right here for everybody. Okay. Can everyone see that?
Yes.
Okay.
I can.
Yes. Perfect. Okay. So yeah, thanks for the introduction. Hi, everyone. Excited to be here and to share a little bit about what we do and how COVID has impacted us and maybe some ideas that might be helpful for the future. So I'm a licensed clinical psychologist, and my department is called SBBH. It's School-Based Behavioral Health. And we're coming up on our 20th anniversary. So it's been around for a long time. And, I'm not sure how much of you folks know about our department or what we do, but essentially we, every school has counselors, right? I'm sure you're all familiar with that concept. We've all met with them when we were younger. SBBH has something a little bit different. Our specialists are called behavioral health specialists. So it's like a counselor, but we focus really on therapy. That's what we kind of do in the school. So it's actually really amazing. And when our team gets kind of burnt out and we're really tired, I always remind all the BHSs that as tired as we are, our kids are really lucky to have this service. I mean, could you imagine being a kid and just having access to a therapist at the school? And I'll explain the process a little bit about how kids can work with us. So typically, someone at the school will reach out to me and say, "Hey, we've got a student that they're showing symptoms of maybe depression or anxiety," or it's not uncommon to get a phone call from a parent that's saying, "Hey, our kid's expressing some suicidal ideations. What do we do?" So in this case, they might have already tried talking to a counselor, and maybe that didn't go very far for whatever reasons, and they need something a little more intensive. Our department can kind of go in and we can meet with the student. We can conduct evaluations. So we do emotional and behavioral assessments. So that's going to be things like we'll get a cognitive score for them. We could potentially diagnose the student. We do there's fine motor testing. We have social workers that also help out, and we'll conduct kind of a family history, and it'll all come together in multiple reports. So I'm sure a lot of you folks out there have seen kind of these neuropsychological assessments where they're going to have all the components I just listed, but in one report. Whereas the DOE in my department specifically, we actually do each member does a different part of the report. So they're very similar, but we just have a lot more collaboration with our team. So on top of that, we also do I do supervision. So I supervise 9 behavioral health specialists right now. We work with a lot of different departments, and COVID has made our life very interesting. And sorry, I'm looking down. I've got several notes that I just want to make sure I'm addressing. And one last thing is, we provide services, what it's called, and I'm sorry if you folks if this is redundant for you. If it's not, well, it won't be. But so our services are either on the grid or off the grid. And what that's talking about is it attached to the IEP, or isn't it for whatever reason? And it's kind of complicated to explain what the differences are, but just know that this is kind of it can be a mandated service, or it can just be off the grid where it's just the right thing to do, and we've got to track a kid that might not have a clinical diagnosis. So let's talk about how things have affected us since COVID. We've gone almost completely virtual. And, I'll never forget when COVID first started happening, everyone's life was really in disarray, including my own. We just didn't know what the next step was going to be, what things were going to look like. And a lot of the kids weren't attending, and a lot of the behavioral health specialists would reach out to me and say, "Hey, I can't get anybody on board. The kids don't want to do virtual therapy." And everyone was kind of worried how we're going to reach these kids. Fortunately, it didn't take very long for it to kick in, and then a lot of students were attending regularly. But classes were all, were mostly virtual for most of the year. And the higher risk kids were in classes year round. So that didn't really affect it too much, but our therapists had to learn how to do therapy online. Part of the problem was, and I got to explain the neuropsychology, I guess, of it first. I don't know if you folks have ever been on a bus or a train, and heard a conversation. Somebody might be talking on the phone, and it's not unusual to be frustrated by that. And they've kind of worked out why that is, and it has nothing to do with somebody just being maybe annoying or just inconsiderate. What happens is the brain likes closed loops. It likes to know what both sides of the conversation look like. So when you're only hearing one part of it, it's very frustrating for the brain because it wants to complete it. That's why a lot of the popular music now is so repetitive. It's just our brains like that kind of stuff. So the same thing works when you're talking to someone virtually. Your brain's trying to work out what's happening with their eye contact, and if they're not looking at you, what's going on, and their body language, that it can't quite finish the loop. So the first thing was everybody was just fatigued with this online therapy. No one knew why, and I had to kind of delve into it and kind of explain it to my team, and it made a lot more sense after that, but didn't get much easier. Everyone just reported feeling kind of one step removed from the process. They couldn't quite feel like they could be as effective initially, but once rapport was kind of reestablished virtually, they did a lot better. So that was one of the impacts. Another thing that we're noticing is, just generally poor involvement. And I receive phone calls like this, I still receive them honestly every month, but initially it was a lot more often. It's just, hey, we've got the student in the class, he's not participating, he or she isn't. They're shutting their camera off, they're telling us that their Wi-Fi is not working, and then their parents are coming back and it is working. But it's been a lot of that, getting the student engaged and involved, and it's difficult to do. And I've got some ideas for that later on that I'll discuss, but for now, that's one of the ways it's impacted us. So a lot of the students have really utilized the virtual services. It's been really cool. We've gotten a lot of good work done virtually, a good therapeutic work, but still, confidentiality issues and privacy. No one's going to really want to talk about their frustrations with their mom when, she's 10 feet away, with which it could be troublesome. So that's been one of the issues we've been working with. And we found some ways around it where, the student might type something really privately, and then, our BHSs will respond, through headphones. And that's been kind of a workaround. Another issue is, I think our BHSs should win some kind of international award for creativity, because they got plastic tarp set up, they got fans, they've got air purifiers, and with very little instruction. They really just set up these kind of sterile spaces that look like these mazes, but they work. And their creativity was pretty interesting. They were sharing pictures initially of what their setup was, and some of the principals gave away their own personal air purifiers from their homes to kind of help our team out. And we've had to be really creative. So we can give IKEA a run for their money if we ever go into business. And also, lastly, there's just higher levels of avoidance. Just a lot of the kids are finding ways around not paying attention, and if they're home and they've got a lot of high interest activities they can interact with or engage with. Some of the ways our interagency collaboration has been affected, I think it's become easier. I'm sure a lot of you folks work in big teams with different cases, and it's so cool to just come together and not worry about parking in a place, or if key person doesn't attend. It just seems like these meetings are much smoother. We get to business a lot quicker, and they do really seem more productive to me. And I've been able to attend a lot more of them, because you just don't have to, drive as far. So I think in some ways that from my perspective, the interagency collaboration has been much better. Phone calls, Zoom meetings have been really good. But we've got to talk about what we can do to improve, right? How can we make things better in this environment? So a couple ideas I had, and I bounced some ideas off with my team. New technology would be good to make classes more engaging. There's a lot of apps out there. We've tried. So we've done Google Classroom, which has been pretty cool, which is basically, it's these virtual classrooms our BHSs have put together, and, they'll add, like a little, I forget what it's like, an avatar of them, and certain, YouTube videos the kids can watch and certain things they can do, but it's been kind of underutilized, unfortunately. So, we think different technology would make probably a world of difference in just getting the kids more, I guess, engaged with the classes. I think classes are great in person, and then our meetings going virtual. That's been great. And what I shared earlier, it's just more flexible, collaboration's easier. What I think would be helpful for everyone, and this is, I'm a little biased here because a lot of the meetings I attend have a lot of different folks. We work with a lot of folks from Department of Health, sometimes different schools, different states. And, calendar app usage would probably be helpful because a lot of the meetings I go to, there's usually at least 10 people in them. And, I'm part of, 50 emails that are, hey, can you do this day? Who can do this time? And, there's apps we can utilize, and that would make meeting a lot easier, which is just, you pick your time slots, and, hopefully they'll all align when it's all said and done. A couple more recommendations. I think clear guidelines around how we utilize our resources would be helpful. No one really knew what they were doing, where they were making their kind of sterile, therapy rooms. And I mean, I think that was a worldwide thing, but now that we've kind of gotten a little better, it would be good to see what other people are doing and have more involvement in that. Actually, practice-wise has been wonderful. I recommend we keep using that as much as we can. And I've got a little screenshot of what it looks like after this slide, but it's essentially a way to track what our therapists are doing, and then what the actual change in the student looks like. And it's been really helpful. There's still a lot to learn around the program, but I think that's a great start, and maybe seeing more wide use of it would be great too. I also like the idea for more baseline testing, even creating our own. I know there's some budget issues always around the corner, and I think getting more students on board with just some regular baseline testing would be helpful, and make screening them a lot easier. Also, more family involvement. I've got some ideas for that in a couple slides. I'm coming up on 2 minutes left. Okay, so this is a screenshot of what a practice-wise dashboard looks like. I don't know if anyone can see my mouse here, but essentially you've got the interventions one of our therapists used, and the date, and then this one here, they talked about goal setting these 2 days, and then psychoeducation. No, that's not psychoeducation. That's a relationship rapport building there, and then you can kind of see the relationship. Excuse me, at times there's an increase in involvement with the student, but you can measure a lot of different things with it, and you can kind of see what's working, what's not working. You can make kind of guesses, and it's a better way to kind of conceptualize what's going on with the student. So psychology is kind of one of the softer sciences, so having something like this I think has been really helpful. I think streamlining our meetings going forward is going to be helpful. I'd like to see more just kind of general meeting templates, because we attend a lot of meetings, and to kind of have something a little more anchored in what's our goal and let's try to accomplish it would probably be more helpful for everyone. But still, I think the interagency involvement's been awesome this past year. And then next steps, this is my dream list here of what our department might be able to do at some point. Psychoeducation, I don't think there's enough of it, which is just, explaining to teachers what anxiety is. I mean, you wouldn't believe how many meetings I have to go to where, a teacher will, be frustrated with the student, and you can explain the biology of ADHD. You can explain, what the negative outcomes, untreated ADHD prognosis, and they'll kind of still go back to, well, this guy's just lazy. How come he's not working harder? It's it happens all the time, and I'd just like to see a little more, material on it where that's accessible for all kinds of people, where it's like, oh, this is a real thing, and this makes a lot more sense. So it's kind of a way to just get a little more compassion with the teachers. Sorry, I'm running a little bit over. I'll try to wrap up here. I'd like to see more video and courses for parents. One of the biggest requests I get is, where can a parent do parent training? And there's just really not enough of it. So I think if we got stuff together that was, there's just a lot of parent training stuff out there that's really solid, that I think we could incorporate. I would also like to see sharing of updated practices to teachers, just let them know what's empirically working. And then for whatever reason, I chose a weird font for the quick trainings, but I've done a lot of trainings for teachers, and they're usually really tired. And I taught for 2 years. I get it. At the end of the day, when I was teaching, the last thing you want to do is like a 2-hour training, or at least for me. So I just like to see a little quicker things of maybe some emails, or, hey, there's a 10-minute training just on what anxiety looks like in the classroom. I think that stuff would go a long way. And that is it. Sorry, I ran about 2 minutes over, everybody. Apologies for that, but there you have it.
Excellent. Thank you very much, Toli.
You're welcome.
That was outstanding. Just a couple of other housekeeping things as we begin to transition. One is, well, first, thank you for being mindful about the time. Toli, maybe could you stop sharing screen real quick? Then we'll go back to the presenters.
Yeah, sorry about that.
No, thank you very much.
You're welcome. There we go.
Thank you. So now we're going to pivot to CWS. As we pivot to CWS, if participants, one thing I forgot to mention is any questions or comments, please feel free to put in the chat, and that'll be useful because to kind of forecast, we've asked each presenter to go about 15 minutes, and then at the end, we'll be turning it over for a larger discussion for a lot of people, a lot of faces that you're seeing here. So folks can ask questions to a few people, one person specifically, any particular agency, anything like that. So those we have somebody in charge of keeping track of those questions. That is that piece right there. Now transitioning to CWS, we have the pleasure of having 3 presenters, a nice trifecta. I'll do the quick introductions and then we'll start. So starting off with Tonya Mahi. She is the Assistant Child Welfare Services Branch Administrator and has been with the department for 30 years now. She grew up and currently lives in Kaneohe, Hawaii, and is married with 3 children from ages 16 to 30. She received her bachelor's degree in social work from the University of Hawaii at Manoa and her master's degree in social work from the University of Southern California. Tonya has been involved in child welfare services for over 30 years now. For 10 years, she has served as an assessment worker investigating reports of abuse and neglect, for 5 years as a supervisor of the adoptions unit that later became a permanency unit, and for 5 years as a trainer with the Staff Development Office, for 8 years as one of the Oahu Child Welfare Services Section Administrators managing the Child Abuse and Neglect Hotline, Licensing Unit, and Title IV-E Eligibility Unit and Closed Files. And for the last 2 years, she has held her current position as the Assistant Child Welfare Services Branch Administrator. So welcome, Tonya. Also up, sorry, I'm looking at my, up next, we have Rachel Thorburn, and she currently serves as an Assistant Program Administrator in the Child Welfare Services Branch at the Hawaii State Department of Human Services. In this role, she develops statewide policies and programs and is responsible for statewide quality assurance. She has been working to improve the lives of abused women and children for the past 30 years. She has worked on social service projects in Montreal, Canada. Oh, I'm gonna screw this up, Rachel. In Guatemala. Could you pronounce that for us, Rachel? Sorry. What comes?
Quetzaltenango.
Thank you.
Quetzaltenango?
Thank you very much for saving me, as well as in the United States. She was the director of the Rape Crisis Center for Hampshire County, Massachusetts, and part of a two-person domestic violence unit at the city attorney's office in Santa Monica, California. Starting out as an investigator, she has been working in child welfare for over 15 years now. And finally, last but not least, we have Teresa Minami, and she is the Assistant Program Administrator for the Department of Human Services, Child Welfare Services Branch. So without further ado, let's turn it over to CWS. Thank you all for presenting today.
Aloha, thank you for the opportunity to present. We've been asked to share a little bit about our experience at CWS, Child Welfare Services, through this pandemic, and how our practice and services and resources have been adjusted or enhanced to support children and families. As it was discussed in the previous presentation, I'm not even sure if I've ever been on a Zoom call before the pandemic hit, or knew what these computer glasses were that help with all of these numerous meetings. So definitely we've continued to grow and learn through this pandemic. I'm very, very thankful for my colleagues, Rachel and Teresa, who helped to put this presentation together and who are going to be presenting with me. So today we've organized our training into or presentation into 3 categories: data and service provision, operations and collaborations, and new opportunities. Rachel will be presenting on data and service provisions at this time.
Aloha. So yes, I'm Rachel Thorburn, and thank you for the introduction. So if you're looking at the data, we have a few slides that have data, and if you happen to be looking at it or doing screenshots, we ask that you, as a sort of disclaimer, feel free to talk about it in this meeting and with your internal colleagues. If you want to share any child welfare data publicly or externally, please check back with us at the Department of Human Services, because we want to make sure that the proper context is given for our data. Okay, so let me jump in. So what you're looking at is all calls to the Child Welfare Services Hotline. So these are not just calls of potential abuse or neglect. These are also calls where people are asking questions. So these are the total calls. And the period of time that you're looking at is each month, the total number of calls each month from January 2018 through December 2020. So this covers pre-pandemic, so you know what it was looking like before the pandemic, and then during the beginning period of the pandemic, right? We don't have it for the last 6 months of data is not shown, but it gives you a lot of the pandemic data and then the period before, so you can compare. So you see that there is some variation, and generally when you see dips, it's months where school is not in session. So you'll see dips usually around, I'll show you here, June and July of 2019, there's a dip when school is out. You sometimes see around December here, like because school is out for the holidays, you'll see dips. So similarly, when you get closer to the pandemic months, as you may recall, things were going along, even though the pandemic was beginning, things were going on fairly normally until March 2020. And then in April, things went virtual with most schools and organizations. And you see that dip here for April. And then it slowly climbs back up to the pre-pandemic levels over the following months. So that's the main thing to note here is there was a drop from the pandemic, but it does climb up and get to pre-pandemic levels fairly quickly. Okay, I'm ready for the next bit of data. Okay, and so now you're looking at the same number of months, January 2018 to December 2020, but now you're looking at cases that intake referred to for intervention. So we have, those of you who are familiar with child welfare, we have 3 different levels of intervention that child welfare intake workers refer cases to. So if at the highest level, if there's high risk or there's a safety factor that's indicated, those get referred to child welfare for investigation. And that's the green line that you see on top. The red line is the cases that are referred to our middle level when there's moderate risk. And we are concerned and we want there to be some services to this family. That's the red line. And those are for voluntary case management services. And then the orange line below that are our family strengthening services. And those are for families where our intake workers assessed that the family was at low risk for abuse and neglect, but there was still some risk and some concern. So you can see these 3 bars, and these are the intake cases referred to these 3 different levels. And it looks similar to what you saw before, which is there's a dip in the summer of 2019 when school was not in session. You see little dips sometimes around December. And then when you move over here to the pandemic, things are moving along kind of normally. And then in April, right here is where you see this dip. And then it moves back up to pre-pandemic levels. You don't see much of a change in the family strengthening services. So that's what I want you to see here. Okay, if we can go on. Okay, so here is where you're looking at who was the reporting source for cases that were referred to child welfare for investigation. So these are not all the calls to the hotline. Of those cases that got referred to child welfare for investigation to the hotline, who was the reporting source? Who called in the report? And then the different colors tell you who it was. So like the red, and then the time period is months, the same months period from January 2018 all the way through December 2020. So these are each month. So that whole period of time is exactly the same as the other slides. And then you can see the colors tell you who is referring. So the red is social service personnel. The darker orange is medical personnel. And I'm just going to mention the larger ones. The that dusty blue is legal or law enforcement. The dark green is educational personnel, and you definitely want to look at the green, that dark green going across. And then there are a bunch of other categories that you can see here. But what you notice, unsurprisingly, is that like the dip you see in June of 2019 here and July, that educational personnel aren't reported. You don't see that bright dark green at all because the kids aren't in school or they're not in school in a regular way. And so similarly here, when you have the dip from March when in the pandemic when school was in session to when it wasn't, you don't see this big green bar that you see in March and in February and January. You see these bars and then that bar disappears. You don't see any green, any of that color in April. The kids weren't live in school and it's very small or non-existent in the following months. However, the other referral sources make up the difference and the total numbers end up being fairly similar to the pre-pandemic numbers pretty quickly. So even though there's a drop, the kids are still being reported by somebody else, it looks like. Someone else, and not a specific source. It's not like, oh, now the police are taking over the educational professionals, like the teachers and such, or the school counselors. It looks like everybody else sort of filled in the gap because it's spread across, the reporting sources spread across all of the potential reporting sources, not just one. So that's kind of what you see here in this data for the pandemic is the drop. And the biggest change you see is in the educational personnel, so teachers, school counselors, principals. And then you see, even though it gets taken away and there is a drop, all of the other referral sources, all the other people who are reporting step in and start reporting those children, we assume, even though the teachers are not. And they start coming back toward the end. Anyway, that's what I wanted to share about the data. And now I'm throwing it back to Tonya to talk about services and how things changed in our operations during the pandemic. Thanks so much.
So in terms of operations, our offices have been open during the entire pandemic, and we've been responding to reports of abuse and neglect in person during the entire pandemic. Of course, we did change our protocols based on the different emergency orders and requirements in terms of needs for personal protective equipment and social distancing, screening questions. And like many organizations, we really struggled with getting PPE to resources to maintain operations. And through the support of the director's office and HAIMA, along with many different community agencies and contracted agencies, I think of Epic Ohana Conferencing and other community partners, even some of our staff started sewing masks when we weren't able to get them. I know through our partnership with our sister division, MedQuest, Dr. Toma, who was deployed to HAIMA, provided us with different trainings on COVID, multiple trainings and informations, and also referred us to resources to be able to respond. We also started, when we responded, normally many times our visits were unannounced. We started changing our protocols in terms of calling ahead. If there was contact numbers, also asking screening questions that many of you are all familiar with. Also trying to do more information gathering over the phone if possible. And then also having families come outside at times to meet, depending on their responses to questions. So in terms of operations, that's was some of the most significant impacts. In April of last year, we had resource caregivers. Those are like foster parents. We call them resource caregivers that were impacted by unemployment that were caring for foster kids. So we found respite funds to support those families. And in July, we received federal CARES funds monies to support our operations. And this assisted us with office fortification needs, like filters that were discussed earlier, and also accessing PPE, and also the different things you see around, like plexiglassing of our offices. We continue to assess the needs of children and families during this period, connecting them to services and resources. And we are very, very thankful that we've continued to be able to hire during this period through the past year. This has been very, very helpful for our operations. And then also the use of technology has been a significant impact. What we did for our ongoing cases, where we meet monthly with families, those between the periods of March and June, we went to doing virtual monthly face-to-face visits. And our Ohana time visits, which are visits between parents and children, those between March and August went to virtual contact only. And through the use of the CARES monies, we were able to provide prepaid cell phones to families to maintain virtual contact. Also Ohana conferencing went to virtual, and also psychological evaluations and counseling services that were historically done face-to-face were moved to virtual. And this doing psych evals was very, very helpful for like, we've struggled in terms of getting psychological evaluations for some of our children and families on the neighbor islands. And the pandemic allowed us to look at providing these services virtually, where historically we would be flying in psychologists to do that. I believe that's all. Yeah, during this time we continued to work on our program improvement plan. Family First Hawai'i is our Family First Prevention Services Act plan. We've continued to implement that during this period. I talked about the prepaid cell phones provided to families during the pandemic. We also, through BESD, our other sister division in the department, we passed out pandemic electronic benefit transfer cards to foster children that were in school during the pandemic. And most of these children would have received a free school lunch. So we've distributed, there have been 3 distributions of these funds during this period. And then I talked about the respite funds that we made available initially when the pandemic hit. And then also the Consolidated Appropriations Act that was passed in December of last year provided for the states the ability to extend children in foster care. We call that program Imua Kako. Normally there are age requirements and work and school requirements. During this period of time, currently to the end of the federal fiscal year, we're allowed to, young adults that might have exited Imua Kako, we're allowed to bring them in to provide financial supports. Also through the Consolidated Appropriations Act, there's these chafee funds that we normally use to support our ILP, our independent living providers, their contracts. More chafee funds were given to the states for us to be able to assist young adults that were formerly in foster care, to assist them with any housing or other needs. The Consolidated Appropriations Act also provided for our current educational and training voucher program to be expanded from $5,000 to $12,000 to be provided at this time. The only way that we have been able to implement this Consolidated Appropriations Act has been through our collaborations with High Hopes, Epic Ohana Conferencing, our Court Improvement Project people. Gosh, I'm gonna forget about people. But it was through meeting regularly, getting feedback that we were able to, and we're just in the process of working on distributing our ETV funds. That's our educational training voucher funds. I believe in terms of collaborations, we have this Child and Family Services Plan vision, and working, this was done before the pandemic in terms of providing supports to children and families like in their community, and doing this through collaborations. And You know, there are so many different collaborations. These are just a few through the Hawaii Interagency State, the Youth Network of Care. We've collaborated with many of the different state organizations, and this is also called for local interagency collaborations. Also through our partnership with the Child and Adolescent Mental Health Divisions, they've assisted us with many of our youth with complex needs that we serve. Also through our collaboration with Child Adolescent Mental Health Division, we created this blended funding like project, a shelter. It's called our Residential Crisis Stabilization program, and they go by Hiki Mai Kala, but we were able to provide crisis stabilization for youth, and also give us a period of assessment to find more appropriate placements through them. We've also been collaborating with the Department of Health through different grants in terms of early childhood development and identification of these children early on. And then I did talk about our Family First Hawaii through the Family First Hawaii Prevention Services Act, and all of our different collaborations through that. Yeah, I can go on and on.
So, Tonya,
Yes.
we need to wrap up. They're asking us to wrap up because we've gone over our time.
Okay.
So-
Okay, that's it. Sorry. Thank you.
No, you're on. Thank you, Tonya.
Thank you all. Yeah, sorry about that. I think what's clear is that there's so many great things to share, so many lessons learned, all about wanting to help children and families and share a variety of things. So thank you very much. It is my regret that I'm the timekeeper. I'm sorry. Thank you very much. I'm going to turn it over to Child and Adolescent Mental Health Division now. And today we have the pleasure of having Max Sender. Max Sender is a research and statistical analyst for the Child and Adolescent Mental Health Division. She graduated from the University of Wisconsin-Madison with bachelor's degrees in math and physics, and has spent the last 8 years designing reports and running analyses on CAMD's wealth of mental health data in order to improve our youth's care. Without further ado, we'll turn it over to Max for about 15 minutes, and then I'll introduce our discussants, Billy Ann and Tiffany. Take it away, Max.
Thank you so much, Brett. Okay. Can you guys see? Awesome. So we are very fortunate at CAMD to have quite a lot of data about our children, both in terms of what types of services they're receiving and how well they're doing from various different reporters. We have data from the children themselves, their parents, as well as the social workers reporting on how well the kids are doing. So just one thing I wanted you guys to be keeping in mind, and just based on your own experiences during the pandemic, what you would expect the data to show in terms of how the pandemic would affect the services that the kids would receive, or how much more or less improvement they might be getting. There's been a lot more telehealth. It's certainly not the same type of services that the kids have been receiving before the pandemic, but it is much more common now. So just a few things, looking at some the applications that CAMD has received for youth to enter our services. And as you can see, there was a very sizable drop-off at the start of the pandemic. Far fewer families were looking to start services with CAMD. Some of that just is because with the pandemic, they're more reticent to go out, and you don't want to be starting new relationships with people you don't know during the pandemic. Also, with the schools not being open for in-person classes, there's a lot fewer referrals from DOE, which is where we get a lot of our kids from. And as far as the services go, a lot of services were had some small amount of drop off, but one of the most noticeable was the crisis mobile outreach. And that, similar to the applications, a lot of that is just youth not going out into the community as much, not being in schools, which is where a lot of the crisis calls come from. But you can see that there were substantial impacts in terms of how many new kids we were getting, and in terms of some of the services that were being asked for as a result of the pandemic. Sorry. So how have youth problems and functioning changed since the pandemic started? It's actually a little surprising to me, at least, though I'm not a clinician, but looking at how both how well kids are doing when they begin services, as well as how much the kids improve throughout their time with CAMD, there's not actually a whole lot of differences at all looking before and after the pandemic started. So you can see here the CAFES score, that's a measure of functioning for the children, and it's reported by the social workers. And this here, we're looking at the CAFES when they get admitted into CAMD. So you can see that's this blue line here, and there's no real change in terms of how well the kids are doing. Just for some additional context, the higher the CAFES score, the more functional impairment the youth has. But either way, there's it's just sort of a little up and down, no significant changes looking before and after the start of quarantine. One thing you might notice, though, you see these bars down here, that's how many CAFESs were actually performed. And you can see that at the start of the pandemic, there was, or rather during the pandemic, there was a lower number than there were previously. That's mostly due to there just being fewer youth enrolled in CAMD as a result of having fewer intakes. Next, talk about the Ohio scale. The Ohio scale is a measure of functioning as well, but we have two different reporters on it. We have the family, or sorry, rather the parents that do a report on it, and we have the same questions that we also ask the youth. And so we have, between the Ohio scale and the CAFES, we have information on how well the youth is doing from the parent, the youth, and the care coordinator. What we can see here, and just a quick rundown, the gray is the total score, and the blue and red or orange, I'm not sure what color that is, but those are the subscale scores, the externalizing in blue and internalizing in orange, I'm going to say. And what you'll notice, what you'll notice is that the scores don't have a particularly significant change. They do get a little more erratic in terms of how up and down they are, a little more swingy compared to before the pandemic, but that's a result of, as you can see from the bar chart at the bottom, there's a lot fewer Ohio scales actually being collected. Just for some additional context, the numbers, the large jump in February of 2019 in terms of Ohio scales collected is because we moved over to a new electronic health record system so we were collecting the data in a much more convenient way for everyone involved. But just as with the CAFIS, no significant changes or differences pre and during the pandemic. Just so you know, this is the data from the parents. I don't have time to show it, but the youth data is essentially the same. One thing we measure, ideally monthly, but in practicality less than monthly, is school attendance. And we ask whether or not the youth attended school in the past 30 days. You can see this goes back a few years. There's the expected dips during the summer break, and then in winter, it dips a little bit. But you can see that several months earlier than you would normally expect, and lining up right with the start of the pandemic and quarantine, there was a significant drop in terms of the number of youth who attended school. Some of that could be just because of school being moved to being virtual, that the way people responded was they were assuming it meant in class, in person, in the past 30 days. But from talking to some clinicians, it also seems that part of it is that it's just easier in some ways for youth to not attend a virtual class than an in-person class. But as you can see, once it only sort of lasted for 3 or 4 months before it went pretty much back on exactly the trajectory that you would have expected from previous years. There are 2 lines here. The gray is the percentage from the parents reporting it, and the blue is from the youth reporting it. We collect this as part of the overall Ohio scale data. One more interesting and was surprising to me, but was very glad to see it, thing that seems to be borne out by the data that we have, is that the improvement that our kids have from their time at CAMD doesn't seem to have changed at all when looking at the fiscal years 2019 to 2020. Now this is certainly not 2020. Certainly is only about a quarter of that is pandemic time, but even so, we see essentially identical trajectories for both the parents and the youth functioning, reporting of the child's functioning from their earliest, when they entered CAMD, to their most recent. So that's saying that the kids that we were getting in 2019 and in 2020 essentially look the same at the beginning and look the same at the end. of their treatment. So this seems to be indicating, and as we saw along with the Ohio scales and KFIS data earlier, the actual treatment and improvements that the kids are getting has been fairly consistent, even with shifting a large part of the services that our youth receive to be far more telehealth based. As far as demographics go, we did have a drop off in terms of total numbers of kids that we saw, but for things like age, there wasn't any new change. It continued in the direction it had been going the previous couple of years. Though it's been plus or minus a year for quite a while in terms of average age and youth, percentage of youth 12 and under, that is also continued the trend that was there before COVID started. And similar to percent of our youth who are female, it continued the slight uptick that it had been on for the last 10 years. So as far as takeaways, or what I wanted you guys to be thinking about after this presentation, in terms of the data for CAMD's youth and the services and that they're getting and how effective those services are, the number of kids that we have took a drop, largely due to the drop in referrals and applications that we received. Some of that just because with no in-person school, there are fewer avenues for actually getting referred. DOE is a large source of cases for CAMD. The outcomes themselves seem to be largely unaffected. We are seeing the same improvement before and during the pandemic, which is very nice to see. So it seems that even though the sort of means of delivery of therapy has had to adapt with quarantine, our kids are still receiving the same quality of care that they had been previously. And there haven't been any demographic shifts, or at least they don't seem to have been impacted by COVID beyond just the raw numbers. Anyone has any questions, please put them into chat, or you can email me or David Jackson or Trina or Emoto. And we'll be happy to give you more context on the data if you like, or answer any questions. I know I ran through this a little quickly, but thank you guys so much.
Excellent work, Max. Thank you very much. Thank you to all of our presenters. Now we have, we're going to turn it over to Billy Ann and Tiffany. So two quick introductions with regard to their backgrounds, and we'll open it up. I was thinking we'd open it up for if they'd like any initial reactions, thoughts, and comments they might have, and then we can start answering as time permits questions from the audience. We have at least a couple of ones in the queue already. So first, I'd like to introduce Billy Ann Bruce. Billy Ann is a strong-minded and extremely motivated individual. She is someone who is willing to help anyone in a bind, is always hoping for the best, and aims to inspire the best in people around her. She was the president of the East Hawaii High Hopes Board for 2 years and served a total of 5 years as a member. Billy Ann is currently working as a youth partner for Epic Ohana, providing both peer support and supports advocacy to her current foster youth. These opportunities to serve the community have brought immense joy and purpose into her life, creating a clear path for her endeavors after her post-secondary schooling. So thank you very much, Billy Ann, for being one of our lead discussants today. Second, we'd like to introduce Tiffany Dara. Tiffany is a former foster youth who served on the High Hopes Leadership Board for 7.5 years, advocating for systems change in foster care. She also serves currently as a young fellow with the nationwide Jim Casey Youth Opportunity Initiative. During her time in foster care, Tiffany received mental health services, which drives her ambition for her current work and future goals of maintaining a degree in psychology. Tiffany currently works as a youth partner with Epic Ohana and works directly with youth receiving CAMD services. She uses her lived experience to help the youth she works with to learn and advocate for themselves and develop positive coping skills. She is passionate about helping to change the lives of the youth she works with. In her free time, Tiffany likes to write poetry and go to the beach. So without further ado, a special welcome for our lead discussants, Billy and Bruce and Tiffany Dara. Welcome and thank you very much for your time. Let's turn it over to you guys for we can go however you guys want. You can give us initial reactions and thoughts. We can jump right into questions and comments. What would you guys like to do?
I just have some initial thoughts and just a couple of questions. So thank you all so much for your presentations. They were very helpful and very insightful. And I just want to say thank you to all of you for all the work you do for our young people and our families, especially during this time. I know that anxiety is really high for our young people and our families. So having your guys' support definitely is super helpful. I wanted to uplift as things that I thought were very helpful from the DOE's presentation. So things like therapists on school sites, I think that's great for accessibility, and all of the changes you guys made to accommodate COVID and make sure that young people still had access to that support is very helpful. I think that your kind of future endeavors as far as adding more psychoeducation will just continue you all on this great path that you're on. I think that a lot of times young people aren't able to kind of identify mental health concerns that they may be coping with just because we kind of brush them off as characteristic traits when really there's a larger underlying issue. And I think that a lot of young people that may be more on like the high functioning side often don't see it either because they kind of don't have that saying like it's a characteristic thing, but nonetheless, they're still coping with it. So I think that teacher and parent trainings are a great way to kind of inform parents and the public on these kind of issues. For child welfare, again, thank you so much for your time and for sharing with us. I think that things like the Ohana visit times and the resources for families like the phones, so they have accessibility to virtual things, as well as the PEBT. These are things that I've seen families and youth use as I've been working with my peers. So I know that these things have really come in handy for our families and our young people. So just thank you so much for making that possible. And then I think that child welfare is really awesome in collaborating with community partners and kind of keeping us all up to date on the needs of the young people that they serve. And I know that there are so many community resources that really just want to help. And it's so great that you guys are in constant communication and really allow those community providers to support the families as well. I was kind of wondering if you guys feel like there's going to be like an influx, like a large influx after the pandemic, like when kids are going back into school and they're adjusting and they're back in contact with teachers and kind of those mandated reporters, if you think you're going to see a change in reports.
So
I think we're going to be very, oh, sorry. Go ahead, Rachel.
Oh, that's okay. I can jump in and tell you a little bit of my thoughts on that issue, which is that we're likely going to see a rise in cases in child welfare, but it's a real combination of factors. For one, during depressed economic times, there's historically nationwide, there's an increase because of the increased stress on families. So we saw this post 9/11 when the economy of Hawaii was really in a recession because tourism was low, right? And so similarly with the pandemic, a lot of people lost jobs, right? And a lot of families are struggling in ways that they didn't. And you usually don't see that increase in cases immediately. You usually see it a little bit later. Like with the pandemic, with 9/11, we saw it not immediately right after, but like a year or two later, when those stresses on families have really gotten bad, and then and the resources are lower. So I do think we're so that's one piece that I think we're all trying to get things out to the community now to try to like mitigate that potential possibility, you know, like potential outcome of the pandemic. But it's likely we'll see something. And then there's also something that we've seen in terms of families coming back to child welfare who had been stabilized, but during the pandemic or toward the end of the pandemic, we're not at the end, but at sort of this point in the pandemic, some families coming back. And some of that, this is a theory and, you know, a hypothesis, so no need to put this in writing, but a lot of the tools that we had given families that we had worked with, like why don't you go to a neighbor and ask for their support, or call on your mother, your sister, your auntie, or take the kids out to the park. A lot of those resources and tools that we had given families to help when they were under stress, families that may have had been at risk for child abuse and neglect, those didn't work in the pandemic, right? We had this whole set of skills and tools we'd worked on, but they weren't for this new environment, this new world, this new pandemic world. And so similarly, like we're all having to relearn and reteach and come up with new tools and new skills and teach them out to the families as well. So there are a couple of things that I'm worried about that may come together to cause there to be a rise. But again, Antonia mentioned, we are going out with prevention services in larger numbers than in the past. So, you know, with fingers crossed, maybe we'll be able to mitigate some of that. So those are some thoughts that I have, but I did see that Talia wanted to jump in as well. I can step.
I couldn't have said it. Yeah, I can't say it more eloquent than that. I was just going to say it's going to be really crazy. So you nailed it. But thank you.
Okay, excellent. Then now, would it be okay, Tiffany, to turn it over to you if you had any initial thoughts or reactions or whatever you want to share would be great, and no pressure. We can always open it up to Q&A too, but wanted to protect some space for you in case you wanted it.
Yeah, definitely. I wanted to piggyback off of everything Billy said. I felt everything she said. Thank you, everyone, for everything that you presented on. I totally agree with all the comments that Billy had shared. Also, with what CWS had also shared with the CAA, the Chafee funds. I know EPIC is working tirelessly also to help get those funds out. Us as youth partners, we are also making those calls every day, getting those as well. Calling the young people up to age of 26, you know, helping those young people who have had experience in care, getting, you know, some extra money, because, you know, everyone has been hit hard by the pandemic. So it's definitely been a blessing in disguise for a lot of these young people. And also with the ETV, you know, the educational training voucher being extended from, you know, the limit of 5,000 to 12,000. And then I also agree that there should be those parent trainings like you were talking about with the DOE. Like I agree, those would be amazing. And then you were saying quick trainings for teachers, like about what anxiety looks like in the classroom, because I mean, it's as simple as like a child, you know, shaking their leg, right? Like those are little signs like that something may happen, right? I can be sitting here and you guys can't see it in a computer, right? Like like you were saying in your presentation, you can't read body language through a camera. And so it's definitely, we've all been affected by COVID in some way, shape, or form. And I think that all of these changes that each and every one of you have made and have, been doing for the youth that you're working with in some way, they've been making a change in some lives. One other suggestion that I may throw out there, for CWS, just for like visitations. I know you guys do, like, if the family can't do in person, you do the virtual visitation, but like for siblings, I'm not sure how that is working. Like if you do like a virtual sibling visitation, if that is a possibility, because if there's multiple siblings, I know we have big families here. If there's something that could be worked out a little more, because I know that that's something that we try to advocate very highly for. Some of us have like 5, 6 siblings, and we try to get them all together somehow, some way. So that may be something, that some of the funds could go towards, getting them like at their foster homes, a device that they can all have like a weekly visit on or something, if they can't all come together in person. But just a thought. But I can turn it back over to everyone else so they can do your Q&A. But those are my thoughts.
Thank you very much, Tiffany. Thank you, Billy Ann, as well. Also wanting to honor youth and family voices. So please jump in. All the questions are for everybody on the panel right now. Anybody can take it in any order. If I'm tracking, we got a question from Susan Rocco. I think a bunch of questions have been answered en route. I think this is one of the few outstanding questions. Susan asked, have the data trends held constant in the first 6 months of 2021? So I think anybody and everybody could take a stab at answering that. I think Susan is big picture. I don't want to put words in her mouth, but again, maybe it's about just trends now that we're in calendar year 2021. And again, to reiterate Susan's question, have the data trends held constant in the first 6 months of 2021? So anybody and everybody, please weigh in on
I'll go
that.
first on this one. I don't have the data on hand for most of it, but I know we're going to be sending out or sharing the presentations after this, but I will make sure to include some additional information on what the data look like for the last 6 months.
Okay, so I think I'm probably the other data person, and I'm sorry to give the answer of I need more time to analyze. Part of why the data that I showed stopped in December was I felt pretty solid about all of that, and I just need more time to say anything much about what we're seeing in the last 6 months. So come back to me in a couple months, and I might have more to say. I'm sorry, I'm reticent to say anything that's not fully, that's only half baked right now.
Thank you, Max. Thank you, Rachel. Any other thoughts about that? Or maybe, look, I think we've answered, as far as I can tell, we've addressed all the questions. So if from any of the panelists, or anybody, maybe we could even expand to speculation or hypotheses. So for example, one question was about, are we expecting increases, probably increase in the uptake of services? And I think that was a resounding yes. So any thoughts, Scott? Dr. Shimabukuro, looks like you're unmuted.
Mike, I think from national research, we can expect a greater need. I don't think if you look at CAMD by itself is a very good ruler for that, because our threshold is very high. So how it affects everyone below that threshold is not visible in our data set. And I'm quite frankly, I'm very concerned about that group because that they tend to be less visible. So that's my speculation.
I just have a quick comment, Brad. This is Leslie Slavin. One thing I've been feeling like kind of positive about is that it seems to me that stigma of trying to get help for any kind of emotional difficulty is really decreasing. I've just never heard so much about mental health in the mainstream media all the time, you know, and not just about, you know, criminals with mental health problems. I mean, about everyday mental health issues being of concern for schools and families and everybody. So I think that might, I mean, that might make it a bigger demand in the future, but maybe in a good way that it would help people get help earlier.
Outstanding talks by our leaders at CAMD. Thank you very much, both Scott and Leslie. Maybe we'll turn it over to, I got one last comment from Susan, and we'll kind of give it to a wrap. I'll read it out. A number of students have expressed the stress and anxiety of trying to keep up with coursework via distance learning. So it may be that some kids will actually experience a reduction in anxiety when they return to in-person learning. So yeah, there seems to be a lot of different moving pieces to this equation. I really like Leslie's hopeful spin on that at the end. I would agree with that. It's a pretty interesting time, and that's I think it's all about access right now. So on that note, any and all closing thoughts from any of our panelists? Oh yes, sorry. So I'm going to turn it to all panelists for any closing thoughts. No pressure. I'll do one last housekeeping thing as a friendly reminder. It's a friendly reminder, as Tommy put in the chat, remember that this presentation has been approved by the National Association for Social Workers for up to 1.5 CEUs. And in order to get your CEUs, social work CEUs, you must do two things. Complete a forthcoming Qualtrics survey, entering your name and email to match what you registered with and what you'd like to put on your CEU certificate. And we're looking for at least 90% of time in session, so sort of automated Zoom metric in there. And also, regardless of whether or not you're looking for CEUs, we will be sending out a satisfaction quality improvement survey, always looking for things that people enjoyed and did areas for improvement. So on that note, any closing thoughts from our presenters here? Anything else, folks?
I think I'm just looking at the participants, and I see some names of like service providers and a lot of community support. So I think like special shout out to all the panelists for all you guys do, but also just to all the other community workers and service providers that are out in the community and really supporting our young people and families, because right now it's just really hard times. So I know that our families and our young peoples really appreciate your support.
Thank you very much. Couldn't think of a better way to end it. Billy Ann, so polished, so professional. Thank you very much. Thanks, everybody. Have a great day.
Thanks,
Closing this
everyone.
out.
Thanks.
Bye.
Bye. Thank
Bye.
you.
Bye.
Thank you.
Thank you. Bye.